We're gonna move right into our next session, which is diabetes advocacy and legislation. So we're moving kind of from the science of the morning into research and now into policy. Shireen is the Executive Vice President for Government Affairs and Advocacy of the American Diabetes Association. She has worked for more than a decade to reduce discrimination against people with diabetes in a variety of settings. She now provides the strategic direction and oversees the American Diabetes Association's advocacy efforts with a focus on increasing federal and state funding for prevention, research, and treatment, all very important, and also continuing efforts to eliminate discrimination against people with diabetes. So, Shireen, thank you so much.
Thank you. So as the person who's coming later in the day, you can all signal when you've heard that before, hopefully by not falling asleep, but gently letting me know that you've covered that before, because that would be helpful to me. So I begin by talking about, what is advocacy in the diabetes world, and I have a name. And I begin with some who, because that's important to us and what motivates us as a patient advocacy organization. So I begin with the guy up the top there. That's Tim Duffy. That picture was taken in the Kashmir, where his job was blowing up mountains, the snow, so that other people could ski down. He's saved someone from the top of, top of Kilimanjaro. I mean, he's an adventurer kind of guy, and what he wanted to do was run a kayaking business in Alaska, and they said the Coast Guard, he needed a little certificate to be able to captain a little boat, and they said, oh, no, people with diabetes can't do that. You wouldn't possibly be safe. So what he signifies is what gets in the way of people with diabetes is ignorance of the disease. So what needed to happen for him to be able to do his job was we need to make sure that the law protected people with diabetes, and we had some issues with the Americans with Disabilities Act that we needed to fix. Talk about that later. And we also needed to have a team. In that case, one of our lead volunteers who was a lawyer, another volunteer who was a doctor, really educating the Coast Guard about what it means to have diabetes and why this guy who can hang out in Kashmir can also motor a little boat in a little stream in Alaska. That next guy in the middle is Jared, and he went to start school in Florida. He was ready to join his brothers in school, and he was told, no, where you are here in Duval County, Florida, we have 103 elementary schools, and there's 5 that will accommodate you. So basically, if you want diabetes care to be covered, you're going to be segregated with the other sick kids in those 5 schools. So his mom didn't think that was a great idea, so she along with other diabetes advocates in the American Diabetes Association, fought to change the law in Florida so that kids with diabetes could get the care they needed in schools and no longer be segregated. And then there's Delonte Lewis. So he was diagnosed as a young person, and he had one of those really tough love docs. And the tough love doc said to him, you don't take care of your diabetes, you're going to die pretty soon. That sort of scares a young guy. But then he lost his job in the recession. And when he lost his job, the insurance company says no one with diabetes need apply. So he, and when we went into health reform and fighting that effort, was fighting his own battle. He knew what he needed to do to manage his disease, but he couldn't find an insurance company that would take him on, despite the fact that he was living, until that point, quite well with his diabetes. So 3 different stories, but what they all have in common is they all need a cure. So what we just heard about all the wonderful science that's going on at NIDDK, they all need that. They all need what Ann talked about earlier, Ann Albright earlier talked about it, the translational work that's happening at the Centers for Disease Control, the Division of Diabetes Translation, and all the studies that they're doing. They all need health care. They all need access to a world in which someone like them can't be turned down simply because they have diabetes. And especially all of them, but I think about little Jared especially, need a world in which we take healthy living seriously so that he can go to school and get a lunch that's not only good for kids with diabetes, but for kids who are trying to avoid type 2 diabetes. So they have different stories, but they have a lot in common. And now I get to see if I know how to switch this. So these are the 4 areas when I was introduced, mentioned briefly that the association focuses on, and I mentioned that just so you should know where we're coming from. These ideas come from our going out to the diabetes community, to patients, to healthcare providers. What are the things that are in the best interests of people with diabetes, which is our guiding star. So you'll see our focus is on increasing federal and state funding for diabetes prevention treatment, preventing diabetes, primary prevention, improving accessible real care that makes a difference in people who are trying to manage their disease, and ending the discrimination that people live with. So I'll be going through some of those, as many as I can get through with you today, but feel free to interrupt with questions. I welcome that. So I really don't know what I say about how important this federal funding is when you've had two wonderful speakers who've told you all about the important work that they're doing. If they haven't convinced you, there's nothing I can say, but hopefully they have. I mean, what they have been doing is making a difference in people's lives in ways that in the 12 years that I've been working in the diabetes world, the differences and the changes and the hope that people have, it's amazing to see the difference. But what's really scary is the other side of it, which is the epidemic of diabetes. We know that, every 17 seconds, so about every time I can get through one of my long sentences, someone's diagnosed with diabetes in this country. So today, 240 people are going to undergo an amputation because of diabetes. Around 48 people will go blind because of diabetes. 120 people enter end-stage kidney disease. So we can talk about it's a tough budget time, and everybody here knows it's a tough budget time. But this is an epidemic that's not going away. It's not going away for the 26 million American children and adults with diabetes, or the 79 million with pre-diabetes who sit there on the edge of the precipice. And it's expensive if we don't manage this disease. So I know it's not an easy time to get money, but I also know diabetes isn't going to go away if we turn our back on what NIDDK and DDT are doing. If you don't know, hopefully you know those acronyms by now, but if you don't, it's inside the Beltway, but I will say what the acronyms mean. So we've been working hard to fight for those additional funds, and it has not been easy. This year has particularly been the opposite of easy. So we went into fiscal year 11. We had a 1% cut at the NIH, and we had a really, a 1% cut means some of that promising research that we just heard about may not be funded, even though we know we're getting somewhere with it. CDC had a very devastating 11.4% cut, which means that not only the national program, the Division of Diabetes Translation, but 50 programs in 50 states that are providing that are providing good care and education for people were all cut about 10% throughout. So then we move along to the Budget Control Act, and so far we don't know how that's going to hurt us until the Super Committee finishes its work. I mean, we know that there is a set-aside to protect Medicaid if a deal isn't reached, which is something that impacts people with diabetes greatly. Medicare impacts people with diabetes greatly. We also worry very much about what will happen with CDC and NIH. In the middle of that, we're also dealing with fiscal year 12 and 13 because you always want to deal with as many fiscal years as possible. So fiscal year 12 just is beginning to come down now. I know that this fiscal year ends in, 3 days, but the rumor is the government's not going to close down. So we will go on trying to get a fiscal year 12 budget. The Labor HHS Committee has come out with their bill, and it protected CDC from further cuts. I mean, that we should be adding more money, and I hate to be in a position where we're just happy we didn't get more cuts, but we're happy we didn't get more cuts. NIH did not fare that well. I think it was a 1.1% overall with NIDDK. Oh, no, it was 0.6% with NIDDK being 1.1%. So that was not good. A good piece of news, and I'll be talking about the National Diabetes Prevention Program more, but that's the effort that we just heard described, how we've actually figured out how, or they, the scientists, I won't own it, have come up with programs that can prevent or delay over 50% of people with diabetes. And every time you talk to anybody on either side of the aisle, or you talk to someone in the administration, or you talk to someone anywhere, they say, that makes sense. We put all this money into doing this program at NIH. They figured it out, and then CDC got involved and helped translate it, and we got the YMCA involved and United Health Group, and everybody figured out this way to take science and move it into the community at this really reasonable cost. And everybody goes, that's exactly what we should be doing. And indeed, we got that included, the royal we, in the Affordable Care Act, but it's been hard to get it funded. So we were really pleased to see $10 million. And what we need to do, and I'm sure Ann Albright can speak more fluently, this is how we can use that money to set up an infrastructure that can take what we know and bring it to scale. And the scale is large, but we know we can make a difference. So there's just one other thing as I'm talking about victories out of order there, which is the special diabetes program, which was just mentioned. Half of that money goes to type 1 research, and you saw what a big difference that money has made since 1998. The other half goes to programs geared towards the Native American and Alaska Native communities, which are the communities most disparately impacted by diabetes. So what you see there is a wonderful book that we used last year when we were talking to Congress about that bill. And it's a story for every state. So in one state it will say, here's a story of a type 1 family involved in the Teddy trial in their state. And the next page would be someone in a tribe and how that has impacted their lives because, throwing money at something, you want to see the results, and this showed the results in real people. I want to move to health reform because it's huge for the community of people with diabetes and other chronic diseases. And I think one of the ways to explain why it's huge is Jessie McDonough. So there's a lot of diabetes in Jessie's family, and she knows what it means when she gets diabetes if you don't take care of herself, because she's seen what's happened to other people. Because if you don't take care of yourself, then you end up one of those people who goes blind today, one of those people who loses a foot, one of those people who goes into dialysis. And she knew all that. She's educated. She knows that. She's going to take care of her diabetes. Oh, this is great. Her husband loses his job because he becomes disabled. She loses her health insurance. She can't get health insurance. So what's she going to do? Well, the doctor says take 2 shots of insulin a day. She says, I can afford 1 shot of insulin today. So when we fought on health reform, we're thinking about Jessie, who couldn't get anyone to insure her, and she said our family made $100 too much for the free clinic. So she cut down on her insulin and on her care, even though she knew where it was sending her. So when we looked at health reform, and it was controversial and it was partisan, we were saying people with diabetes are outside the fence now. And lots of people have health insurance, and they're one job loss away from not being able to get health insurance. So a big part of what we were looking for is to end the discrimination that people have, both in being accepted into insurance programs and having to pay. You can have insurance, but we're going to charge you 5 times as much, so that in essence you can't get insurance. So both of that was happening. We needed to set up a system which people couldn't use up their insurance. So getting rid of both the annual and the lifetime cap on insurance. We are all, some people say we're all temporarily without a disability. We don't also want to be temporarily with insurance. So one of the things to get rid of was how easily one could find oneself kicked off one's insurance if, you stopped being healthy. So putting strict controls on rescissions, adding limits on out-of-pocket, and because diabetes disparately impacts poor communities and elderly, there was a lot of focus on what was going to happen in the Medicaid program and the Medicare program, and also a focus on prevention. And those were the sorts of things that we looked at as we went into health reform. So one of the, and I'll point to Lauren, who is with me today. She said when she saw my slides, do you realize those aren't in English? I just want to make sure you realize that they're not in English. And indeed, I did realize that but it was good because other times I didn't. But that's in Vietnamese, for anybody who doesn't speak Vietnamese, and in Spanish, which you probably recognize. So a lot of health reform is you get it passed, and then if people don't understand it, what good is it? So a lot of the work that we have to do in the diabetes community is get the word out in the languages that people speak at the whatever level they can both understand what's going on. So we've worked to try to get information out to the community, because there is an enormous amount of misinformation about the health reform and what it means, and whether you want to call it Obamacare or you want to call it a savior, it's a difficult bill, and it's difficult for even people to spend their lives working on it, but the basics about what it means for folks has been quite a struggle to get that information out. So now I go to sort of where are we now with healthcare reform, and the first is defending it. So you can tell that at least it's my opinion that it's absolutely essential for people with diabetes that the Affordable Care Act be implemented. We haven't ended the discrimination that people face. So I started a little pool in which I said to people, I put no money on it because that would be wrong. But what's the biggest threat to the Affordable Care Act? Is it A, Congress, B, states, or the court? Anybody want to vote here as to which is the biggest threat? I'll tell you amongst the people I hang out with. I see a vote there. Congress, all right. Anybody for the courts? Courts, the states? So, yeah, I mean, it's exactly it. It all breaks down. So the way Congress can get rid of the Affordable Care Act is, to completely cut it off or to starve it, to take funds away. So that's what Congress can do. Now, what the states can do is sort of interesting. If you look at what various states have done, some states have worked to implement it, and it's hard to implement. It's a complicated bill. Others have passed legislation saying we won't implement this or we won't implement that. Some have sued the federal government. Some have done all three. They've worked to implement it. They've taken funds to implement it. They've passed legislation not to implement it, and they sued the federal government to try to get rid of it. So you see states doing sort of all sorts of things, and there's a huge part of this that they need to be working to set up the exchanges, which will happen in 2014. And then there's my friend, the courts. I'm a lawyer, so that's where I like to, see where it all ends up. So far, there's something like 27 lawsuits. 3 of them have been decided by courts of appeals. The first one, the Sixth Circuit in the good old Midwest, said this thing's constitutional. The 11th Circuit in the Southeast, where I was a law clerk 1,000 years ago, said, no, this thing is unconstitutional. And then the Fourth Circuit, which is in Virginia and Maryland all around us, said, oh, no, this case isn't right for us to decide. But were we to decide it, we would find that it was constitutional, which is sort of a long way of saying that there's 9 people, about a mile and a half from here, sitting in the Supreme Court, who know how this is going to turn out. May not know yet, but obviously that's where it's headed. So as we try to defend what I think, again, is crucial for people with diabetes, we sort of see 3 places in which there are both threats and gains. And while that's going on, we need to be implementing health reform. And implementing health reform means keeping track of sort of an extraordinary number of regulations. The American Diabetes Association alone has written letters, either by ourselves or groups, on 40 different aspects of the law. Some things have already gone into effect. Very popular, kids can no longer be discriminated against because they have a pre-existing condition. By far, what seems to be the most popular one is that young adults can stay on their parents' insurance plans until they're 26. Now, it might be that everybody I know has kids my age, and that's why we all find this really exciting. But there was a New York Times article last week that highlighted a young woman with diabetes at the University of Maryland who said, but for this, what am I going to be able to do? Because I can't, go out into the world and get a job that's going to have health insurance in this economy. So there's protection from being dropped. We've gotten rid of the annual limits, the lifetime limits. We've restricted the annual limits on coverage. There's right now a pre-existing condition insurance plan, which allows people with diabetes to get coverage until we set up these exchanges. And I'm sure that many of you are familiar with this whole process, but in 2014 we'll end all discrimination against people with pre-existing conditions, and they'll be able to go into these exchanges and get insurance. But until then, the PSIP is there. The donut hole for seniors is shrinking. There's coverage of free preventative services for a number of things. I'll sort of get into in a little bit what is and isn't covered then. grants have been set up to set up these exchanges in the states. In fact, today's grant day. The community transformation grants are being announced even as I speak by HHS, which is one set of grants that came out of the Affordable Care Act. Another set of grants are specific to Medicaid, which were announced about September 23rd. And in all of those, we're finding ways in which communities and states can look into primary prevention and care for people with diabetes and other chronic diseases. Sort of the other things that are sort of right now in the process is menu labeling. My favorite picture there, although I don't think you can see it here, but it's the Whopper with cheese, $6.99 and 1,590 calories. Coming to a Burger King near you. So if you travel to New York, you will have already seen that there. And hopefully it will help people make wiser decisions. And the other thing we hope it will do is give a nice incentive for them to have other options for people who really don't want to get most of the calories that they should have in a day through their Whopper. So I think as we begin to see it, we'll see. But that's something that we fought for because at least people should have a chance to know what they're getting into. And once you look into this stuff, I can promise you there's going to be something that surprises you. It might be that low-fat muffin that you really thought, I got the low-fat muffin. Yeah. All right, fine. So it's only 600 calories and not 750. But at least will give us, give Americans a fighting chance of sort of understanding what they're up against. So we're in the middle of dealing with the regulations on that. I mean, we really love the regulations. One thing we were really disappointed by is that it exempted the movies and for those of us who like, I got to get baseball in because it's the time of year, but for those of us who like to go to the baseball game, we won't know what we're eating there. But one thing I can promise you, when I got angry about that and I looked up the popcorn, it's the worst thing you can eat. So just know that stuff is really evil. So anyway, we're in the middle of getting those pieces in. We're in the middle of working with a lot of the consumer protections. There's another one of the prevention pieces is a Medicare prevention and treatment plan, and we're working out the regs about that so that seniors can come in and actually get a plan to move forward on preventing chronic disease. The hottest games in town this fall, the essential health benefits. So what's going to be covered in the exchanges, there's going to be a minimum that's called the essential health benefits, and that is enormous because if that doesn't include what people with diabetes need to care for themselves, then we're back to the Jesse and the Delente stories of people not being able to care for themselves. So we've been obviously talking about what's important to manage your disease because insurance that only helps healthy people is not all that useful when you have a chronic disease. I shouldn't have used the healthy as the opposite, but people who have a chronic disease. The other thing that is large right now is that there's a draft rule about how the exchanges will be set up. It's about 200 pages, but it's a quick read. You obviously have read it. Yeah, no. And anyway, so there's a lot of details about how they'll be set up both federally and at the state level. So a number of things that are sort of going on, but also if you think about what's going on in health care, it's not just about the Affordable Care Act. I mean, it's also about things in Medicare and Medicaid, some of which are happening inside the Affordable Care Act and some of which aren't. So there's been a lot of threats to Medicare and Medicaid. I'm sure you've all heard that. And one of the things is that the Affordable Care Act said there should be a maintenance of effort so that these programs don't all go south while the implementation process is going on. So there was language on the House side to get rid of that, which was defeated. So that was good news. What you see right there, the Medicaid's impact in Tennessee and in Hawaii, which I get to go to tomorrow for a conference. I have to also get that into the any speech I give, right? But that's something that we did with the American Cancer Society, the Lung Association, and Families USA, and it's a wonderful report that talks about the impact of Medicaid and what it does for people in chronic disease, but broken down by state, so that you can, if you live in Tennessee, you can understand how many people with cancer, with diabetes, with lung disease are being impacted, how many people would lose coverage. I mean, if we got rid of the maintenance of effort, it was estimated something like 300,000 kids, 300,000 people, mostly children, would lose their coverage. So I think getting the facts out about who's covered and what would happen. And again, you cannot treat diabetes and then you pay for the amputation. You can either pay for the foot care and you can pay for the medications, or you, and by you I mean society, can pick up the bill for the amputation when the person comes in to the hospital. When this was announced, we had a press conference, and one of our lead volunteers is Gina Gavlak, who has type 1 diabetes herself, and she says, I've had type 1 diabetes for decades, and I'm doing great because I have great health insurance, but she both works in diabetes and as an emergency room nurse. And when she spoke, she said, and yesterday before I came, I was in the ER, and someone came in from an accident. And when I looked at this person, they also had this humongous sore, this horrible infection. And why? Well, I was dropped from Medicaid. I realized that meant I wasn't taking care of myself. I realized as someone with diabetes, but I had no coverage. There was really nothing I could do about it. I was really trying to stop this infection on my own, and it's probably just really lucky that she got into an accident and ended up in the emergency room getting care. That's not how people should have to get care. So we're trying to protect Medicare and Medicaid. I'm not saying there's not ways to cut down on how much they cost the country. What I am saying is that keeping people like that out of care and throwing them into emergency rooms is not going to save money, it's not going to save legs, and it's not going to save eyes, and it's not going to save people's kidneys. Another piece of the insurance puzzle is the what we call Diabetes Cost Reduction Act. So because people with diabetes were having trouble getting covered in the last decade and a half, we passed legislation around the country which said if you have a state-regulated plan, it needs to provide coverage for diabetes. In other words, you can't sell care that doesn't provide, in many cases, education, because diabetes education is the first step in knowing what you're doing, and care. So those exist in 46 states and the District of Columbia. But there's an interplay with the Affordable Care Act that could be problematic. I talked a little bit before about the essential health benefits. So if what we need is covered in there, that's great. And if not, states will have an incredible incentive to get rid of these mandates, because otherwise they're going to have to pay the cost for the people that they need to subsidize under the Affordable Care Act. So hopefully we'll be covered in the essential health benefits, but otherwise we run the risk of people with diabetes being sort of in a worse situation than they were before, which is certainly something that we can't afford to happen. I'm now going to move over to primary prevention, and I know that's something that other people have talked about today. That great picture there is Al Franken along with some of our staff and volunteers. Senator Franken and Senator Lugar were the senators who first introduced the National Diabetes Prevention Program, and that's taking that wonderful program where they showed you can prevent diabetes in over 50% of the cases. Science does it. We translate it into the communities, and now we need funding. So that when I mentioned before that we'd gotten, the royal we, that the Senate Labor HHS Committee put $10 million into it, that comes out of that being passed in the Affordable Care Act, but being one of the many things in the Affordable Care Act that was passed but not funded. So we're working on the funding piece of it. The other thing that I want to sort of talk about, and obviously I'm doing it out of order here, is screening. So if you want to stop an epidemic, you might want to know who has the disease, and you might want to know who's about to get the disease. So that means screening people who are at high risk for diabetes. This is about a $10 test. It doesn't have, you repeat it, but it doesn't have false positives. It doesn't lead you to do surgery if you have it wrong. I mean, it is about the simplest and most effective test for any disease out there. And yet we sort of have a battle about getting high-risk people screened. Now, we shouldn't screen everybody. We should screen people who are high risk, and we, the American Diabetes Association, NIH, CDC, sort of all agree who that is. We've got that down. That's not really questionable right now. So if you're over 65, Medicare will pay for your screening. That's good. No cost to you. This is good. But it's a little more of a problem if you haven't reached 65. So in the Affordable Care Act, one of the great things they did was have at no cost screening for a number of things. But those things had to be rated by the United States Preventive Services Task Force as either A or B, meaning, that's their ranking system, A, B, C, D, and I. So for diabetes, if you happen to have sustained high blood pressure, great, you're a B rating, and you can go in and get your blood glucose test, move on to being taken care of. But let me give you somebody else, somebody who is 55 years old, she's obese, everyone in her family has type 2 diabetes, she's had gestational diabetes twice herself, but she doesn't happen to have high blood pressure. She doesn't get screened. They say it's inconclusive if we should screen that person. Therefore, it's not no-cost screening, so it's not included. It's a travesty. I mean, those are folks who need to know if they have diabetes for treatment. And they need to know if they have prediabetes so we can do all this great science, we figure out how to do it. And we're supposed to do that for the people with prediabetes, but you got to know who those folks are. So one of the things that we have yet to get fixed in this world is this whole problem with not screening everyone who is at high risk for diabetes. Although a little high note on that, which is another part of the Affordable Care Act, an amendment put in by Senator Mikulski at the end said, let's look at what women need in terms of screening. So an Institute of Medicine panel recently studied that. So what you all may have mostly heard about is that's the one that said free contraception. So yeah, that's what got all the news. So Sue Kirkman, who you heard this morning, went and testified on our behalf, and she came back, she said, I don't know that I was so brilliant, but they were all so glad to hear someone not talking about contraception for a few minutes that I think I convinced them. And indeed, Sue did. And so now if you are pregnant and you're at high risk at your first prenatal visit, you can be screened for what would be type 2 diabetes that already existed, and then everyone is screened at 24 to 28 weeks. This is near and dear to me because I had gestational twice, and I had absolutely no risk factors for it, and I'm one of those people that wouldn't have been screened but for a doctor who was incredibly ahead of his time back then, and have healthy grown-up kids, so I feel good about it. But it's huge. It's huge. I mean, 18%, an estimated up to around 18% of pregnancies in the United States, women have gestational diabetes, and I'll talk a little bit more about that. But the screening issues, we need to clear up the rest of it. We've gotten the elderly, we've gotten the pregnant women. Let's get the rest of this worked out. So the other part of prevention is sort of looking upstream. And that's at our youth and what's going on. How do we get to a place? Right now we're facing that 1 in 3 kids born in the year 2000, I think that's right. Thank you, Ann. Will get diabetes in their lives, and if they happen to be minority kids, it's closer to 1 in 2. I mean, that is not acceptable, and that's the future unless we take action. So, one of the things we've seen from the initiation of the Let's Move movement. Obviously, it is the First Lady's priority. It's given a lot of national attention, gotten a lot of collaborations from the public-private sector around that, and the legislative success out of that is the Healthy and Hunger-Free Kids Act. So what that did is put more money into school lunch so that you can actually have healthier food at school lunch, which is a good idea. Getting rid of junk food in schools. I mean, it's interesting. A dozen years ago when I got to the ADA, and Fran Kaufman out in Los Angeles was saying, let's get rid of vending machines in the LA Unified Public Schools. Like, what? Get rid of vending machines? Or get rid of the crap out of vending machines. And, they saw that the boys were drinking over 2 sodas a day out of those vending machines, and the girls were not very far behind. And that's a heck of a lot of completely useless calories. So another thing that this law does is it it will get that junk out out of any place you can buy the food there. And it's going to provide assistance for local wellness programs. So we're really excited to see that. This year, we're working on what's called the Fit Kids Act to try to do the same thing for the physical education piece, to try to take physical education as seriously as we take other things. I mean, you can learn a lot of science and math and English, and if you are sick, it's really hard, and you face a life of chronic disease, it's not going to be that easy to utilize everything you've learned. So the Fit Kids Act says, let's take physical education seriously. You know, when my kids, the only class you were allowed to take online in high school was health. It shows that's the one they thought was the least important for our kids. And then the other part of that we find important is at the state level, and there are a number of states that have been very, what I would call progressive in terms of seeing the connections between what happens in the school. So it's not just that kids spend a lot of time in school eating, but it's also role modeling for what they should be doing. And so a lot of the bills at the states, and there's been about 15 in the last year or so, have been around school nutrition, PE, physical activity, you know, a little bit giving kids time to get out there and get exercise and physical education. So I want to then just talk about a couple of other things that I think are really important at the federal level. As I've mentioned probably a number of times, diabetes, everybody can get diabetes, but it disparately impacts certain communities much more than others. So one of the bills that we've been working on is the Eliminating Disparities in Diabetes Prevention, Access, and Care Act, or EDPACT, because you need an acronym or it's not really a bill. So you know, what's the problem? Okay, so if we look at the United States, 7.1% of non-Hispanic white Americans aged 20 or older have diabetes or have diagnosed diabetes. 12.6% in the African American community, 11.8% in the Hispanic and Latino community, 8.4% in Asian American Pacific Islander communities, and I heard reference earlier that you had talked about how people at a lower BMI in those communities, lower weight, are getting diabetes, and 16.1% in Native American and Alaska Native populations. I mean, there are places where you don't find anyone who doesn't have a family member who doesn't have diabetes. So the point of this bill is to improve the research that's specific to those, the education that's specific to those, all the ways in which we can impact those communities, doing enhanced public health education, culturally appropriate education. So it's an important bill for us. It recently was put into and introduced as part of the larger Health Equity Accountability Act, which is the act that the Tri-Caucus, which is the Hispanic Caucus, African American, and an Asian Pacific American caucus put out together that deals with a great number of disparities issues, so it was included in there as well. Another bill that we care about that is also a part of that larger bill, but also separately introduced, is what we call JEDI, which is just a cool name for a bill. Not that I actually know what a Jedi warrior is, but you know, it's our gestational diabetes bill, and you know, talking about 18% of the pregnancies in the United States. We're talking about danger to both the mom and the baby. So it's both what happens at birth, where high birth weight babies can have all sorts of problems. Mothers can have preeclampsia. So it's the medical problems these babies face, but it's also the future they face, because both the mom and the baby face an increased risk of type 2 diabetes. So part of this is to follow this group and to use the prevention efforts, because we've identified a group that's really high risk. Or the other thing they can do is start working for the American Diabetes Association like I did, and then you think about diabetes all the time, and then you work hard to prevent. But, you know, assuming we can't hire all of the 18% of American women who have gestational diabetes, I think it's really important that we have some efforts that are really focused on this, because if we want to stem the epidemic, we actually can identify these babies at birth at being at high risk or higher risk for diabetes. Another bill that we have, another initiative that we've had over the last few years, although not introduced this year because of everything that's going on with the Affordable Care Act, is the diabetes screening and Medicaid Savings Act. And that goes back to we need to screen people with diabetes, and we need to make sure that people with diabetes have care. And in Medicaid, it can be, it's one place in one state and one place in another. But guess what? Diabetes impacts your body, whether you're in a state that has great coverage or not. Last piece on the federal level is I've talked a lot about federal funding in science. I want to give just a little talk about stem cell research, which is something that's sort of an ongoing. As you may recall, President Bush first opened up lines, a limited number of lines for embryonic stem cell. But the scientists told us this is good, this is great, but our hands are getting tied. We don't have the stem cell lines that we need to move the science forward. So President Obama did an executive order which opened up not all stem cell lines, but those done under ethical guidance that his administration put together. And then when that happened, we got back to court. So there was a lawsuit saying that violated federal law, which doesn't allow federal funding for destroying embryos. The argument being that the federal funding doesn't destroy the embryo, it's using the stem cell line. So the first judge that saw that threw it out and said you can't do federal funding. And then the appellate court said, yeah, you can, at least until we get it figured out. And then the district court said, didn't change its mind, but on the merits, decided that funding of stem cell research can go forward, and that's being appealed. So right now, the good news is it's from the perspective of people with diabetes who are so anxious for a cure and better treatments, is that right now stem cell research or embryonic stem cell research can be funded. And there's funding at both the state and the federal level. So some states fund, like New York, California, a number of others, they actually fund stem cell research out of their state funds, and others actually try to criminalize stem cell research. So there have been a number of bills to criminalize stem cell research, none of which have actually passed. My personal favorite was the Octomom bill, which was to prevent Octomoms in Georgia. That was like last year's thing, but you remember the Octomom thing? So there was a bill to prevent people from carrying multiple fetuses on, and at the same time criminalize embryonic stem cell research. So it was an interesting mixed bill, but did not pass. I'm now going to switch gears sort of entirely and talk about fighting discrimination, which was mentioned in my introduction as well. So, and I mentioned in a couple stories, and people with diabetes face discrimination, at work, at school, in correctional institutions. If you're on the street and you have a low blood glucose and they think you're drunk and they throw you in the drunk tank and take away your food, that's a problem. And your medications. We had a lawsuit in Philadelphia. People got sick. Who'd have thought? And in public accommodations, so people being able to take their sharp objects on airplanes after 9/11, that was a big deal. People being able to keep, we had a great lawsuit that Justice Department brought against Clear Channel, which owns a massive number of concert venues, and they thought that anything with a syringe was probably bringing something bad into the concert venue. And we convinced them that not all syringes hold heroin, some actually hold insulin, and that people needed to hold on to that stuff. So discrimination comes in a lot of places. The one thing that I will say, one overline, is if the decision makers who discriminate against people with diabetes spent the day as you're spending the day, learning about diabetes and understanding how it works, discrimination would plummet. Because so much of discrimination is ignorance. It's, here's this guy right here, John Steigoff. He was a mechanic at UPS, and they said, well, you can't hold on to your job because you can't get a commercial driver's license because you use insulin to manage your diabetes. Well, he didn't drive trucks. He fixed them, so you don't need a commercial driver's license to do it. If you had to drive around the lot, he had a commercial driver's license from Minnesota, and that's as far as he went. So, a number of things go. First, we needed to fix the law because the law at the time would often say to people with diabetes, well, an employer could say, and this is what UPS said, we don't think you're healthy enough to do this job. And then when you say, well, I'm going to sue you because that's not right, I can do this job and I can prove to you I can do this job, they would say, well, diabetes isn't really a disability, so you're not protected from discrimination because you're doing so well with your diabetes. And really this happened over and over again. So, and I love that picture because he's the mechanic fixing the law. So we fixed the law and expanded a couple of years ago the Americans with Disabilities Act Amendments Act, which basically says, yes, we're covered by the law, now let's get around to whether the person can do the job or not, and not futz with the rest of that. So that's sort of an example of the kind of discrimination that we face in the workplace. What that was, and I'll give you another example in a second, is the whole too sick or not sick enough. But then the other big piece was blanket bans, which is no one with diabetes need apply. And that's Jeff Capshe there, and he wanted to be a police officer in San Antonio, Texas. And they said, basically, no one with diabetes need apply because you'd have to drive a car, and people with diabetes can't drive cars. And indeed, that went up to the Fifth Circuit Court of Appeals and got turned around, went back and back, until finally they ended that blanket ban. I mean, there are some people with diabetes who can't do some jobs. There are some people who don't know when their blood glucose is going low and wouldn't be a good candidate to carry a gun around. But that's not everybody. And all we ask for in civil rights law generally is for everyone to be looked at as an individual. And here was the perfect person as an individual. So great story, happy ending, not quite. So he goes along doing this, and he actually ends up working at another police department, moving up the ranks. And one time he's working with the FBI and the FBI agency. Jeff, you're just great. You should apply for the FBI. And he goes, I've always wanted to work for the FBI. I got to tell you, I got to admit, that's always been my goal in life. So he says, but I don't want to go. I went 7 years of litigation of this diabetes thing. I don't want to go through that again. Can you check and see if this is going to be cool with the FBI? And everybody checked, and they said, yeah, no, it's fine. FBI didn't have a problem with it. So he went through the whole thing and passed all the tests and took the extra training, blah, blah, blah. And they said, it's not that you have diabetes. It's that there's two ways. He has type 1 diabetes, and you can get your insulin, there's three. You can get it through injections, through either a syringe or a pen. You may have heard about that earlier today. Or you can use a pump, which is sort of considered the more high-tech, cool way to do it. So he used syringes. He had absolutely fabulous management. There was absolutely nothing wrong. And the argument was, well, if we send you to Iraq, I didn't know they sent FBI agents to Iraq, but apparently they do. What if you're, then you should be on a pump. But actually, it would be better to have syringes because they don't break. But anyway, so that goes to trial, and it goes to a jury here in D.C., and the jury, so there's two arguments. This is before the new law goes. The first argument is, you can't do this job because you're not safe because you use these syringes. And the second is, you manage your diabetes so well that you're not covered under the law. Well, the jury sort of looked just like y'all are looking like, oh, come on. And they found in his favor on both, and we all celebrated. I wish I could tell you that was the end of the story because you probably want to get on to your other panels, but there's one last piece of this, which is it's right now an appeal. It's on appeal at the Court of Appeals. The federal government has appealed it not on whether he can do the job or not, but on whether he has someone with a disability. Now, everybody agrees under the current law, which has changed, that he's covered, but they're arguing, well, under the old law, you wouldn't have been covered, which we think he was. But anyway, it's currently on appeal, so invite me back, and I'll give you the end of the Jeff Capshe story. But that's the sort of discrimination, a lot of different issues sort of rolled into one to sort of explain to you what employment discrimination is about. Now, it's interesting because the Department of Justice, as you'll hear in some of the other things I've talked about, has really been a friend of ours on a lot of different cases in the Civil Rights Division. But the United States government as an employer, there's some great places and there's some really crappy places. For John Steigoff, the mechanic, we worked and have finally worked out so that you can get a commercial driver's license. It's a process, but you can do it. The FBI, we think, has probably changed their policies, but they're still fighting this. There's another case on appeal right now in the Fifth Circuit, a guy who for 20 years had been a park ranger, and then they decided it was unsafe for him to be doing that because he had diabetes, and he'd been doing it for almost 20 years, and that case is right now on the Court of Appeals. So there are places in which the federal government is a great employer, but we think they should be, leading the way, and it's really a shame to see these cases still going on. Let me move to kids. So when I used to just do the discrimination piece and not the rest of what I've talked to you about. And so I would say, I spend about half my time on discrimination against kids with diabetes, and people would say, so she spends like half her time eating bonbons because like no one's going to discriminate against a little kid with diabetes, so she must have a lot of free time. Turns out I didn't have a lot of free time because turns out they do discriminate against kids. So what do kids need? The kids who are older need to be able to manage their diabetes so they don't miss half of physics class in high school because they have to go down to some office, and they don't wander around the halls when they're feeling low. They just need to check their blood glucose and do it. Not a big deal. Probably good for the other kids to see and get used to people with differences. So one of the fights is around that. The biggest fight, and it leads to the second one, is about care. So little kids can't do their insulin on their own. I mean, 9, 10-year-olds, they can do it. But really little kids need someone to help them. And then any kid is going to need help if they have an emergency. If their blood glucose goes really low, there's this wonderful thing called Glucagon. You give somebody a shot of it. It can't hurt them. They might throw up. They might get a headache, and you're going to potentially save their life. It was developed for nitwits like me who are not doctors or nurses to do. So the big fight is about who's going to do this stuff for kids. So school nurse. And now that would be great. That would be great to have school nurses to do it, but mythical school nurses are not really good for this. And by mythical school nurses, if there isn't a school nurse to be there, then you have to let someone else do it. So what we have is the entire medical community of diabetes experts saying, yes, so what you do is you train someone, because even a full-time school nurse, which is a rarity, is not going to be there on the field trips and extracurricular activities. And diabetes is a nasty little disease that happens 24/7. So one of the big fights is about whether you can train someone who volunteers to do insulin and glucagon. And the answer that some schools have is, well, no, we don't have nurses, but so we'll just segregate these kids. And that was Jared's story. We'll take 98 schools out of 103 in Jacksonville, Florida, we will make non-accessible to this kid with diabetes. It's my 10-minute warning. All right.
We want to leave a little time for questions if we can.
I am almost done. All right. So preventing segregation is sort of the third piece of that puzzle. And so what we look at, I'm not sure how well you can see it, but there's a little girl and she's on a tightrope. And so is there a safety net for her at school? And if you can imagine dropping a child off to school and thinking, what are they going to do if my child has an emergency? They're going to call 911, and I live in Montana, and that's 30 miles away. Or I live in New York City, and it's 4 blocks away, and you can't get there without a half an hour in traffic. I mean, that's not the answer for things that can easily be done. So then my last story is the California saga. So I could go on more than my 10 minutes, but I will shorten the story because it sort of brings it all together. In California, we've been involved in litigation since 2005. So what was happening is that kids weren't getting insulin. So there was one nurse for every 2,200 kids. 5% of the schools have a full-time nurse. Over a quarter of the school districts don't have any nurses. I wish there were more nurses. ADA lobbies for more nurses and nurse funding. But the fact is, there we're talking about a mythical nurse providing care for kids. So what happens in that situation is kids get sick. They get sick at school because their blood glucose isn't managed well. Or they go on blood glucose regimens, which we know don't work. And I'm reminded of a reporter in South Carolina who wrote an article about when I had diabetes, 50 years ago in school, we just knew we'd grow up and probably go blind and lose our limbs. There was nothing we could do about it. Science has given us better ways to control diabetes. Kids shouldn't have to go on regimens so they don't need help, so they don't need insulin in school. Parents were losing their jobs. So this was great. We sued the California Department of Education, a couple of school districts. They settled. It was great. We had a settlement. People could volunteer to raise their hand and say, I will help a kid in school. I'll be trained. Lots of people willing to do it because, everyone has diabetes. Got an aunt and uncle, got a kid. So that was all going really well. And this was the family of the Wolf family and Elizabeth and Lael. And she was taken out of school because the mom had to give up her chance to go to nursing school, work from home. She still found her kid at school with a 600 blood glucose, which, if you're paying attention this morning, you know that's very, very bad. So she had to take her kid out of school. So this was our victory article, journalism, great, you know. About a month after that, we get sued, or the California Department gets sued by a number of nurse organizations that say, no, 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 nobody but a nurse can possibly do insulin. We say 10-year-olds can do it. You know, but so now we're involved in a lawsuit which has worked its way up to the California Supreme Court. It's not gone our way, but the good news is they take 2% of the cases that come to them, and 7-0 they voted to take the case. So we remain hopeful. And I just have at the last thing, who thinks kids with diabetes can be helped by someone who isn't a school nurse when there isn't one around? So all the diabetes experts, the Department of Justice and Education, the California Department of Education, civil rights groups, all saying that we really need to come up with a sane solution for these kids. And so, again, invite me back next year, and I can tell you how that one worked out. So I think I've left a couple minutes for questions just by talking so fast at the end.
Do we have any questions?
I think you mentioned something, was it Glucagon?
Glucagon, yeah.
Glucagon, and where is that, and how do civilians get to get it or administer it?
Yeah, okay, so what glucagon is it's a hormone, and it's actually produced in this country by two companies, Novo Nordisk, who I guess was a sponsor here, and Eli Lilly. And it's, what it is someone with diabetes will get a prescription for it, and their mom will carry it around. They'll have it at the school, and you take it out, you sort of shake it, and you put it in someone. And because it's, you know, think of it a little bit like an EpiPen that you use in an emergency. The difference is that it was developed, well, EpiPen may have also been developed for lay people, but it can't hurt you. I mean, the only thing, if I had a little glucagon kit with me right now and I decided that I wanted to demonstrate on you, you would throw up or you might get a headache, but you can't harm someone. But when you use it is when a child's blood glucose has gone so low that the child has either passed out or they're seizing. And you don't have to get it in a vein, you just stick it in any fleshy part of the kid, and it's life-saving. I mean, it prevents brain damage and even death. And so that's why it's so critical to have someone at the school trained to do it.
You said go journalism. So what story do you want to get told that people don't know about? I'm sure you've got a bunch, but is there anything that really shocks people when you explain what you have to do in your job that nobody's heard of?
Well, that's interesting. So many answers to that. I mean, I do think that the discrimination that kids face and that they're facing these barriers and being able to be safe at school is something that really shocks people, because they can't fathom that kids can go to school and be on the precipice standing over that valley. So I think that's something that people don't know about. I think in the health care arena, I think what shocks people is that we're dealing with 26 million people with diabetes and 79 million people who have pre-diabetes, and most of those people with pre-diabetes, almost none of them know it, that we have something that we can do to stop them from moving to diabetes, and that we're not doing it, that we're not just rolling up our sleeves and putting it into doing. I think that shocks people, and partly because people don't know how serious diabetes is.
Could you explain a little bit further the Gestational Diabetes Act, and also where are women across the country not being followed who've been found to be gestational, where across the country is there a lack of following women who've had gestational diabetes and their children?
Well, here's interesting. You hate it when someone just tells a little story about their life, but I'd say right here in D.C., because I had gestational diabetes twice, and I had to convince my healthcare professional over and over again that I should be checked for diabetes, that I was at high risk, because you know what? I'm not overweight, and that's the stereotype of someone with diabetes. So I don't know whether it's, and I'll tell you where I was checked. When I first had my first child was in Little Rock, Arkansas. So that might be your stereotype that healthcare is more sophisticated up here. I guess I'm example A that it didn't happen to be the case, but I actually don't know, and maybe Dr. Albright can speak to that more, whether there are some places in the country that do a better job of surveillance than others on gestational diabetes.
There is no national system
Sorry.
The system, we're actually trying to do a better job of surveillance in GDM. I actually have somebody on detail in my office right now to try to help us map out that system much more effectively. It is challenging because it's self-report. Did a physician ever tell you that you have GDM? So we don't have county-level data on that. We're not able to do that kind of geographic distribution. We're trying to enhance the national GDM system as we speak.
So I think that's also something that would answer your questions. Why I think people will be shocked to hear that 18% of women have gestational diabetes, and also shocked to think that so many of them, even ones who have really great health insurance, aren't being followed later on who are at high risk. So I think that sort of answers both of you guys' questions.
Where is that bill now?
The bill was introduced this summer. Henry Foster, who is one of our lead volunteers and is an OBGYN from Tennessee, spoke, and we had a wonderful hearing to introduce it. And it's moving, obviously we want to move it forward because we see that as just such a great point at getting at the diabetes epidemic.
Well, thank you very much. We're going to present you our certificate of appreciation from the Press Foundation.
Thank you very much.
We appreciate your being here, and I know you're not going away. So we're going to take a break now. We'll ask for everybody to be back at 3:15. We'll start our final panel of the day. And please, during the break, this is a great time to start filling out your evaluation while you still remember who those speakers were and what they said. And remember, we'd like you to give that to us on your way out after our final panel. So 3:15, we'll see you all back in your seats.
Okay.